Hello. And we just had some weird quirks with the audio there. What can I say? It's a new night. We're trying out all kinds of new things. My name is Kane Treble, and we are here again for another practice KFP session for those of us preparing to sit that RACGP KFP exam. This is Thursday. Thought we'd try something new. Due to life changes and other commitments, I've had to switch it across from the previous Wednesday night sessions through to Thursday. Hopefully this works for all of you as well. Let me know how it does go. We do have options of trying to shift it back, but for my life at least, this would be much more suitable. But, you know, obviously I want to try and help as many people as possible. Now, we did miss last week as well. I had a wedding to go to, and of course I live in the middle of nowhere, let's just be blunt, and had to travel for the wedding. The place I was staying at was expected to have internet and did not have anything. We did not have phone reception. It was amazing, truth be told, but I'd brought all my camera, my gear and everything, and was set to do a live stream, and it all just fell through. So I admittedly didn't schedule anything just in case it did fall through, but apologies for last week. Fortunately, we've got heaps prepared and ready to go for this week, and good to see again some familiar faces here. So welcome for the evening, and of course, we've got practice questions. Now, before we get to the questions, though, I do want to spend a bit of time again on the teaching. Well, marked it up there. So again, we have the date change, but I am still keen to keep this block here as 8:30 p.m. AEST. Again, just fits in with when I can hopefully get my kids to bed. So I hope you'll bear with me on that one. We are 67 days to the 2024.2 KFP exam, so we are on that heading towards the home stretch. Now, I have had enough requests now that I do have to make another suggestion. We are just over 1 month from the CCE exam, and I've had enough people request we do similar to what we do here for the KFB, but for some CCE scenarios. So I am going to switch next week's session to actually be for CCE preparation. If you're studying for the KFP exam, I would still encourage you to jump along and join in on this session. Again, I want to make it nice and interactive so people can get as much out from it as possible, because of course once you get through the KFP exam, and you will, you have the CCE exam ahead of you. So we might just do 1, maybe 2 sessions just for the CCE exam, just to get into the swing of things for that as well. There is a Zoom link that I've included in the comments or the notes for this live stream tonight, and I'll be posting it on the videos and putting out some warnings so that people can join in to that Zoom if they want to join on the night. You do have to be registered for it. It's my one attempt at trying to stop people from just spamming it, but I think if you do want to participate, and again, this will only work if we get people putting things in and kind of turning up and showing up and putting in that work, but I think we can get a lot out of it. Now, I also wanted to highlight, given we are, 2 months or so off from the KFP exam, that you should be practicing KFP questions day to day. I know a lot of people do take a fair bit of time off before the exams to actually prepare themselves in that final stretch. I would say if you feel like that's an approach for you, fantastic, go for it. But you probably should still be working at the moment, and I still want you to be able to integrate your KFP practice into every single case you see, or just about every single case you see. And this is case-based practice. So I want you to look at regular practice, clinical problem solving, and treat every single patient you see as a KFP exam candidate question. Ask yourself, what is the diagnosis? What is differentials? What are the examination findings I'm looking for? Get used to framing things in your head in this way. 1, I think it actually makes you a better doctor. I know, I'm sorry, I hate to say it, the exam may serve a purpose, but it is actually a good way to make sure you are not falling for those traps of going into autopilot mode and sometimes maybe not giving 110% for every patient you see. Can you do it for every single patient? No. No, it'll wear you down, it'll blow out your times. But if you do see a case that kind of sparks that little creativity and you think, oh, actually, this could be a good one to practice with, I would strongly encourage you to just give it a try and see how it goes. Now, the next thing of this is, of course, find other resources, other case studies. And so you'll often find books that are tailored more for the CCE exam or for clinical encounters, but you can actually use them for KFP practice as well. On the Generally Practicing website, I do have a KFP case generator where you put in some basic patient information and it will spit out a randomized pool of questions that can be applicable. And you can use that kind of setup there to quickly generate KFP cases if you want to quickly knock through a couple of practice questions between patients or based on patients you've seen or books you're reading at the time. Now, I want you to also, when you're doing this, focus on applying that theoretical knowledge to those practical scenarios, really addressing, specific diagnosis, management points. Try and do all of those things tailored to that specific patient, to that specific encounter, because that is really one of the things they try and highlight on the KFP exam, that you might be able to regurgitate out guidelines and diagnostic criteria, but if you're not applying it to that specific patient, to that specific cohort, you're going to be losing marks. So again, this is actually a really good way to ask yourself, what is applicable to this patient? What is not applicable to this patient? Why? Hopefully that makes sense. Now, I also, pardon me, I also want you to just practice discussing cases, discussing responses. Ask if you have a few other registrars in your clinic or in your area. This is the perfect time to try and get together, sit down and share your answers, share your perspectives, critique each other. Try and be, harsh but fair. Be more inclined to say, maybe you don't get points for that, this is why I think that, to make sure that everyone isn't falling for those common traps and is really going to get as many marks as possible on the day. Try and get as much feedback from peers or mentors as possible, because that is the only way to make sure that you're not falling for that trap of, I think I'm fine, but my technique is still off. Now, again, I know I've said this a few times, but sit simulated exams. Set aside a chunk of time, and yeah, it's a long time, I'm sorry, and I get it, I've got a young family. It can be hard to carve out several hours in a block to do this, but you've just got to. You really have to prepare yourself for what you will encounter on the day and do this at least, once every couple of weeks, just to make sure your hand doesn't cramp. You're used to writing for such a long, prolonged period of time that you learn how to pace yourself, that you're not actually cutting out time or running out of time or wasting time doing different things. You'll find those little troubleshooting steps will be absolutely invaluable. Look at your performance in those practice exams. Try and work out again, what are those areas that you're not as strong at, and use that to kind of hone in on where you actually need to be focusing your study in these final weeks, because you don't have a lot of time. And again, I don't want you to be trying to learn new syllabus here. I want you to be strengthening up those areas where you're perhaps a little bit weaker rather than trying to just reread textbooks. And of course, take a little bit of time, even 10 minutes at the end of a day, and just reflect on the learning you've had from that day. Reflect on your performance, both in those scenarios, in those areas where you didn't do as well at. Look as well at how much you're improving, and I think it's really important to acknowledge those little gains that you do make day to day, because it can sometimes feel like all this is just insurmountable and you will never get on top of it, but you will, one step at a time. And having these little check-ins, I think, gives you that little bit of confidence to let you know you actually can do this. Try and embrace that continuous learning mindset, because that's medicine, and we're going to be not just studying for exams, but extending our clinical knowledge, our clinical practice for the rest of our careers. And so we should be taking this mindset with a few steps down, not going quite as intense, but using this to help train ourselves to acknowledge that medicine is lifelong learning and gives us that opportunity for eternal growth and refinement. But of course, you're here for questions. Don't deny it. We all know it. It's okay. I've made peace with this. So I think we should probably get to it then. Let's get ourselves 2 minutes on the clock for our first question. Your time starts now. Case 1. Margaret Thompson, a 52-year-old patient, presents at the clinic with newly confirmed hypertension. Her past medical history includes type 2 diabetes mellitus, for which she takes metformin 1 gram daily, and hyperlipidemia managed with simvastatin 20 milligrams daily. She reports no known allergies. You assess her cardiovascular risk profile and decide to commence her on pharmacotherapy in addition to non-pharmacological management. On examination, her vital signs are as follows: height 165 centimeters, weight 80 kilograms, BMI 29.4 kilogram per meter squared, blood pressure 160 on 95, heart rate 78, rest rate 16 breaths per minute, and temperature 36.8 degrees Celsius. Question 1.1. What serious adverse effects should be monitored for in a patient starting on perindopril? List 3 serious adverse effects. Alright, time is up and we have lots of potential answers here, but I want you to really focus in on the serious adverse effects qualifier because that does skew marks towards certain aspects of different responses. So the serious things, the things that can have direct serious negative impact on a person's health, are going to be things like hyperkalemia or hyponatremia. They would both kind of be combined into an electrolyte derangement, and I think if you were to specify each of those individually, you would be getting 2 marks for each, given they are both specific to perindopril itself. If you were to just say electrolyte derangement, again, you're kind of losing some of that consultant level finesse that they're looking for. So you would still get a mark, but you wouldn't be getting additional marks from those. If you were to specify decreased renal function or increased serum creatinine, again, that would be worth 2 marks. And angioedema. Unfortunately, fortunately not overly common, but unfortunately common enough that it is something you do have to warn patients about, and again would be something that I think would be worth those 2 marks. Now, 2 marks for angioedema because it does have more serious implications to it. If you were just to specify edema or peripheral edema, I don't think you would be getting marks, and I would be saying here that the reason why you wouldn't be getting marks for that one is going to be because we're really trying to focus on serious adverse effects, and just some peripheral edema or edema unspecified probably doesn't qualify in on that serious adverse effects mark. Of course, everyone knows perindopril causes the ACE inhibitor cough, but again, because it's not a serious adverse effect, I don't think you'd be getting any marks from here. We do have some responses in from the chat, so we do have declining renal function, postural hypotension, hyponatremia. Postural hypertension in terms of, yes, causing falls, making it serious. Yeah, I think actually you probably would get that over the line. I guess it's usually not that severe for the more old and frail. Having said that, we have specified this patient here does take metformin, has dyslipidemia. We do have a bit of multimorbidity here. So I think given that's the case, yeah, I suspect you probably would actually get some marks there. So well done. All right. We do have other questions for tonight. So let's get another 2 minutes on the clock and your time starts now. Question 1.2. What are 3 non-pharmacological management strategies for hypertension that Margaret could incorporate into her lifestyle? List 3 non-pharmacological management strategies. All right, time is up, and let's get to the answers. So, if you're ever looking for what are our preventable conditions, what are the things we could be doing for it, RACGP has a whole bunch of resources. We should be using our Red Book day to day, and all of this is ripped essentially directly from there. So do be familiar with it. You will see questions like this come up, and it is an absolute treasure trove of responses. So, of course, we have the DASH diet. Now, of course, in this exam, we are really trying to avoid using abbreviations. So I think it's one of those ones you probably could say DASH diet and get away with it, but if we want to be specific, we should be saying dietary approaches to stop hypertension diet. Thankfully, the name kind of explains what it does. They would also accept the Mediterranean diet. Each of those would be worth 2 marks, but I think you would probably not get 2 marks for each of them, given they're both dietary modification. So tied in that as well, if you do specify dietary modification or calorie restriction, yes, you're going to get a mark, probably not as much as if you were to specify a diet in particular, and you wouldn't be getting marks in addition if you had both of those there. Again, likewise, referral to dietitian for an optimised diet plan, really that's diet control. Given it does show that little bit of more kind of finesse to it, I think you probably would get the 2 marks there, but again, lumped into that same group. Just specifying referral to dietitian, though, without that qualifier, yeah, we all know what it's for, but again, we want to be specific and concise in this exam, so I think 1 mark. An important part of lifestyle modification is things like an exercise plan, so referral to either a physiotherapist or an exercise physiologist, and again specifying for exercise plan. And there is a little trick here which I think a lot of people aren't aware of or keep forgetting. If you have a patient who is diabetic and you refer them to a exercise physiologist, if they believe they would benefit from a group exercise class, they can actually get 8 additional sessions in addition to the EPC referrals to participate in those exercise plans as MBS 8115. So to kind of lump that into a single response, you could say something along the lines of referral for group exercise classes for subsidised exercise sessions under exercise physiologist. Done. Now, also, moderate. If we want to hone in and focus in on what kind of exercise we're talking about, RACGP recommends moderate intensity exercise, 30 minutes per day, at least 5 days per week. We also want to specify some of our targets here, so aim to reduce weight to a healthy BMI, being under 25 kilogram per metre squared, or aim for a waist measurement under 80 centimetres for women. We would recommend dietary salt not exceed 4 grams per day. The exact evidence for that's not fantastic, but it's still one of those things we recommend day to day. We would obviously encourage limiting alcohol intake to 1 or less standard drinks per day for females, and encourage smoking cessation if a smoker. Now, it's not actually specified here about the alcohol intake or smoking, and so you would be able to list those things there to get marks from them. Again, we've got responses in from the chat, so we've got weight loss of 5 to 10%, fantastic, and I think adding in that qualifier of 5 to 10% makes that a really, really good short-term goal. 30 minutes of moderate exercise at least 5 days a week, fantastic, and reduce dietary salt to under 6 grams per day. This is an interesting point because it depends which kind of source you're looking for as to what number will be specified there. RACGP uses 4 grams. I don't think they'd be finicky enough to mark it down for 6, but if you're not 100% sure what RACGP specify, you may be safer not specifying that number there. I know the other one that often gets kind of lumped into that category is in terms of calcium supplementation. If you're uncertain, you're probably better off not specifying a dose, not that we're asked for doses much these days, than putting down the wrong thing and potentially losing a mark from it. So Demi here in the chat has low salt diet, less than 2 gram. Again, numbers will change depending on where you look. Weight loss to BMI 25, fantastic. 30 minutes daily moderate intensity exercise, fantastic. Just be careful using abbreviations. I know you're probably doing it just for the chat here tonight, but I want you to treat these questions as if it's the actual exam. Really write it out as you would in reality, because the more you practice doing it the right way, you're less likely to make a little slip and fall for one of these traps in the exam itself. Fantastic answers though, and doing very well, guys. Of course, more questions. Let's get 2 minutes on the clock and your time starts now. Question 1.3. Margaret returns after a month with improved hypertensive control. Her blood pressure reads 128 on 82, but she complains of a newly persisting non-productive cough, worse when supine at night and occasionally on exertion. She denies any fevers or nasal congestion and has felt otherwise fine, denies any loss of weight or breathlessness, and states on 2 days she missed her tablets, and the cough seemed to improve. Her oxygen saturations are 99% on room air, and there's no signs of respiratory distress with a rate of 15. What is an appropriate management plan in response to her new cough? Provide 3 management actions. Doses are not required. Alright, time is up. Let's have a look at the answers here. Now, of course, the number one thing we need to do is stop the perindopril. We know this is the ACE inhibitor cough by this description here, and so the first thing we need to acknowledge is, okay, that probably needs to be given the flick. The next thing, of course, we need to do, we're taking out an effective medication in a patient that needs that. We need to be commencing an alternative. You could be looking at something like candesartan, telmisartan. As long as you're putting some kind of appropriate response in there, you're going to be getting 2 marks. Of course, ceasing the perindopril being the most important thing here, 3 marks. The next thing that I know is one of those stupid things you would do in reality, but you often forget to mention these things in the exam, and does count as a management step, but document the adverse drug event in the patient record. That will stop the patient from potentially going through the same response if a year or two or a time you're away, someone sees that patient and says, oh, they should probably be on perindopril, and tries to switch them over, in which case they'll probably have that same thing again. Now, if you ever get stuck, you can always think of symptom management as well. So there are some things that are known to assist with the cough, and even if you're taking away the perindopril, it does often take several weeks to sometimes a couple of months for that cough to fully subside. And so always a good idea to let them know to stay hydrated. They can suck lozenges, or they can have humidified air if they have a home humidifier to help soothe the throat. The evidence for the humidifier is not fantastic, it never really is, but it is one of those old things that still sits in guidelines time and time again, so there you go. Of course, you've done all these things, you've put all these interventions in place, you want to make sure that you're not going to deal with a different issue down the line, or potentially find out that it was actually unrelated to the perindopril, so you'd be organising follow-up in an appropriate time frame. And again, as long as you're specifying something sensible, I think you're going to get marks there. Again, coming in from the chat here, let's have a look. So we've got cease perindopril, fantastic. Commence telmisartan, brilliant. And review in 4 weeks to assess for ongoing cough. Absolutely love it. Swap to irbesartan, add amlodipine, swap to atenolol. Interesting, good. I would be cautious just saying swap, because technically a swap would imply 2 actions. Ceasing one medication and commencing another medication. And so that could be considered overcoding, and they have said previously that they would prefer you specify that you're stopping one medication as one action and starting another medication as its own different thing. Hopefully that makes sense. Okay, now of course we've got more cases to work on. The night is young. I am not. Let's get 2 minutes on the clock, and your time starts now. Case 2. Sally Heathers, a 45-year-old woman, presents to your clinic with a complaint of intermittent episodes of bilateral hand tremors and muscle stiffness, progressing for 6 months. She describes the tremors as rhythmic, shaking of the hands that worsens with stress or when performing tasks requiring fine motor skills, such as writing or buttoning her clothes. The muscle stiffness mainly affects her hands and arms, causing difficulty with movement and occasionally cramping sensations. Sally works as a graphic designer and has noticed a decline in her work performance due to these symptoms. She denies any significant medical history and takes no regular medications. She has no known allergies. She does not smoke or consume alcohol excessively. On examination, you note bilateral hand tremors exacerbated by posture and action, along with cogwheel rigidity in her arms. Her vital signs are within normal limits. Question 2.1. What are possible diagnoses for Sally's presentation? Provide 3 specific differential diagnoses. Alright, time is up. Let's get to some answers here. So there's lots of things that can cause tremor. With this cogwheel rigidity, this kind of storyline here, of course, the big one that we've got to be considering is Parkinson's disease. Now, other things that can cause similar tremors that you would have to consider as a differential would be things like essential tremor. So it can present very, very similar and takes a little bit of digging sometimes to kind of tease the two out, particularly in those very early phases. Some of the more weird and wonderfuls, of course, you would also keep on the radar. Things like Wilson's disease, quite rare, but you'd be certainly checking the eyes for any of those flashing rings, any history of family history of Wilson's disease, like copper deposition, and certainly one of the first things that most people present with is that tremor to the hands. We also have the kind of less specific diagnoses of dystonia as well. And tied into that as well, we'd also consider things like cerebellar tremor, and we certainly have a little of that component of intention contributing here. Again, coming into the more weird and wonderfuls, chronic inflammatory demyelinating polyneuropathy, or CIDP. We are starting to get, I think, a little bit more awareness of that and probably getting better at picking it up in earlier phases. Certainly the sooner we do pick up on that, the sooner we can commence things like IVIG and actually stop that process or slow down that process in its tracks. Some of our more garden variety things, of course. Common things turn out to be common as it seems. Hypothyroidism. And I've actually had a few patients myself that have had kind of this tremor and excitability, a little bit of hyperreflexia, and sure enough, turned out to be hypothyroidism. There's always that catch-all as well of metabolic disorders. You're not going to be getting as many marks for that, but certainly a lot of metabolic derangement can result in abnormal features like this, and of course, I think you would get a mark for it. Coming into the chat here, we have essential tremor, alcohol use, and yeah, I think alcohol use will probably get tied into the metabolic disorders in terms of deranged liver function. It's the elevated urea and things that accumulate and cause that. There's probably not as many other features there that would have you consider it, and they've kind of pushed you away from that by specifying that Sally does not consume alcohol excessively, but I think would be one of those things you would have to consider. And of course, multiple sclerosis, as you've got there. Jenna, you've got Parkinson's disease, multiple sclerosis, hypothyroidism. Fantastic. So well done to the both of you. Of course, more questions, more fun. Let's get 2 minutes on the clock, and your time starts now. Question 2.2. Sally is worried as she recalls a grandparent who had Parkinson's disease, and she wants to know if this could be the same thing. What is the criteria for diagnosing Parkinsonism? List 3 specific diagnostic criteria. Alright, time is up. Let's get to some answers here. So this one comes from the International Parkinson and Movement Disorder Society, which is a group that meet up of experts in this field to try and get some consistency behind it. Now, you'll note here I've specifically used Parkinsonism rather than Parkinson's disease because they tend to start off with that before to kind of lock in, hey, what could be going on here, before then considering things like referral for definitive diagnosis. So the specific criteria is, the defining feature is bradykinesia with at least one of the following. So muscle rigidity, that 4 to 6 hertz, classic 4 to 6 hertz rest tremor, and or postural instability not caused by other conditions. And if you go to the actual diagnostic criteria, there's a whole heap of conditions listed there. And so I think for an exam like this, just specifying not caused by other conditions, I think you're going to be kind of catching all from that. So it's the bradykinesia plus one of the others. This is one of those things that I think we do well in clinical practice, but we don't necessarily use specific criteria. It's one of those walks like a duck, quacks like a duck, it's probably a duck kind of things, but is fair game definitely for an exam condition. So here from the chat we've got one motor symptom, one non-motor symptom improves with Matapar. You've kind of got it right there in terms of the motor symptoms, the bradykinesia definitely. You could count that rigidity or cogwheeling. But I hate to say, not quite the criteria we're looking for. Again, it's all those things we do look for in clinical practice. Jenna, here we've got the cogwheel rigidity and bradykinesia. Fantastic, and you would certainly get the bradykinesia. The cogwheel rigidity, I think you would get marks there for the muscular rigidity. So look, for a guess, you've done fantastic. And of course, we have here bradykinesia, resting tremors, and rigidity. Fantastic, very well done there. Very happy to see. Of course, more questions. So let's get 2 minutes on the clock, and your time starts now. Question 2.3. You review her presentation and diagnostic criteria and decide she meets the criteria for Parkinsonism. What initial management is appropriate? List 4 initial management actions. Doses are not required. All right, time is up, and let's have a look at the answers here. So we've got two main options that we use in Australia: is commence levodopa with benserazide or commence levodopa with carbidopa. I think if you're doing one of those two things, you're going to be getting excellent marks there. Of course, you wouldn't be doing both of those things because they're essentially the same thing, just working in slightly different ways, and so it'd be one or the other. In terms of dosing, you're not required to know dosing, but for your clinical knowledge in day-to-day practice, it's actually quite easy because they're both just 50 plus 12.5 milligrams orally, 3 times daily, increasing to 100 plus 25 milligrams 3 times daily over 1 to 2 weeks as required and or tolerated. Now, quite common, particularly when you start these medications, patients get quite nauseated, and so it's very common to co-prescribe domperidone for nausea management, particularly in those early phases. And so, again, you don't have to know, but 10 milligrams orally 3 times daily is required, not only needed for more than a week. Certainly warning of that nausea, definitely valuable for clinical practice. Now, of course, the next thing we're going to be doing is referral to a neurologist for diagnostic opinion and referral to physiotherapist as well for co-management of those motor symptoms and instigation of an exercise plan. We do know there's a lot of evidence behind benefit for early referral for physiotherapy in this patient cohort. Now, this patient's also 45 years old, pretty young, and so a diagnosis of something like Parkinson's or Parkinsonism is a fairly significant thing. And again, we know those that get linked in for that psychotherapy or psychological support early also do much better long term. And so I think you would definitely be getting marks there for having that put into it. Coming in from the chat, so we do have referral to neurologist for ongoing management of Parkinson's. Fantastic. I think you get full marks there. Commencement of levodopa carbidopa. Fantastic. Referral to local Parkinson's support group. I think that definitely ties into that support aspect. And referral to local balance exercise group. Yeah, fantastic. I think that would tie in again to that physiotherapy kind of program there, so very well done. Metapar trial, very good. Referral to geriatrician for assessment. Now, probably wouldn't be accepted. A lot of geriatricians have age bracket restrictions as to who they will and won't see, and so this would fall more into the domain of a neurologist, and I think you would be probably safer in this setting for a 45-year-old patient to specify neurologist over geriatrician. Don't know if you get the marks there, sorry. But certainly, referral for PD support group, yes, you would get the marks, but avoid the abbreviations. And again, I know I'm being pedantic, I'm sorry, but I really want you to practice doing this as if it's in the exam. Otherwise, you might inadvertently catch yourself doing this on the day as well. And for that, you wouldn't get any marks if you had just referred to support group. Or you might maybe get a half mark tops. Well done overall though, guys. And I think Parkinson's as well is one of those relatively common clinical encounters that is one of those things we kind of pick up as we go, unless you've had someone that's had an interest that has taken the time and effort to do some teaching for you. I'm not personally convinced it's covered fantastically in the GP training program. Of course, we've got a whole other case here tonight, so let's crack on with it. Let's get 2 minutes on the clock and your time starts now. Case 3. Billy, a 3-year-old boy, presents to your GP clinic with a cough and loud breathing that started overnight. His parents report that he had a mild fever yesterday, but is otherwise well. They note that his symptoms worsen at night and improve during the day. On examination, Billy appears alert. His temperature is 38.1 degrees Celsius, his heart rate is 100 beats per minute, normal being between 80 and 120, his respiratory rate is 24 breaths per minute, normal being 20 to 28. His oxygen saturation is 98% on room air. Question 3.1. What examination findings would be consistent with a diagnosis of croup for Billy? Provide 5 specific examination findings. All right, time is up. Let's get to the answers. So, for Billy here, we'd be looking for things like that classic barking cough. Certainly going to be almost pathognomonic for croup, and so 2 marks will be getting there. Of course, you also often hear that inspiratory stridor to auscultation of the chest, 2 marks. You would expect to see increased work of breathing or accessory muscle use, again, getting you 2 marks there. And sometimes you see, particularly in more severe cases, hoarseness or changing of the voice. Sometimes, in addition to the inspiratory stridor, you'll hear a widespread wheeze. There's a tongue twister for you. Say that 10 times fast at 9:15 at night. And, of course, you can also get fever. In the setting of croup, though, it's fever without signs of toxicity is one of our diagnostic markers there. Now, this is directly ripped from the Royal Children's Hospital Melbourne croup page. And if it's not something you're familiar with, definitely have a read through. A lot of little gold nuggets in there. Of course, we've got some things in from the chat. So we've got expiratory wheeze, fantastic. Intercostal recessions, beautiful, tying into that worker breathing. Altered conscious state, not in here, but definitely I think would be... I wonder if that would be more of a sign of infection rather than a specific diagnostic feature of croup. Inspiratory creps, probably not so much. The creps would tend to imply more of a lower respiratory tract infection, whereas croup is that focal kind of upper respiratory tract there. So again, I don't know if you would get marks for that. And tracheal tug, so again, I think you've got that increased work of breathing, kind of accessory muscle use there. I don't know if you would get intercostal recessions and the tracheal tug kind of playing into it. There's probably a little bit too close a response to those. But again, if you're kind of struggling to think of other things, certainly quite good to try it out. Jenny here, we've got barking cough, fantastic. Presence of stridor, brilliant. And hoarse voice, very good. Got to 3. 3 out of 5 ain't bad. If you get to that point as well and can't think of other things, kind of take that step back and think, well, what else do I see with upper respiratory tract infections? And sometimes you can sneak another 1 or 2 out from there. Again, it can be a little bit tricky to kind of find things, but sometimes a good peck around and scratch around, you might dig 1 or 2 extra marks up. I would say from the responses you got there, though, you'd be passing that question. All right. Of course, we've got more questions here. Let's get 2 minutes on the clock, and your time starts now. Question 3.2. You diagnose moderate severity croup, warranting treatment. What initial management is appropriate? Provide 3 management steps. Doses are not required. time is up. Let's get to some answers here. So, things here we need to do for moderate severity croup. This is again using Royal Children's Hospital guidelines. These tend to marry up quite well though with the ETG recommendations as well, except we'll put a little asterisk in there. We'll come back to that shortly. So, commence oral prednisolone or commence oral dexamethasone. It'll be one or the other. Either one will get you 2 marks. Doses aren't required here, but for your interest, because I know you're interesting. Oral prednisolone, we're using 1 milligram per kilogram up to 50 milligrams as a single dose. Now that's if you're using one of the guidelines. If you're using the other, they will specify plus, with or without a repeat dose the following evening. I would use your clinician gestalt and opinion, what you're more familiar with doing, what you're more comfortable with doing to dictate which one you use. I think there is a lot of ambiguity as to how much benefit you get from the repeat dosing, and so that's a call you would have to make. Now, dexamethasone, 0.15 milligram per kilogram up to 12 milligrams as a single dose. And often for those kids that come through ED, they tend to get the dexamethasone. I think simply because it's a one and done kind of thing. There's no ambiguity around subsequent dosing. Guidelines used to say 3 days of oral prednisolone, but it can be quite difficult, and anyone that's seen kids on steroids knows they're not always the most pleasant little creatures to be around. Now, another piece of management here is to assess if no improvement after 30 minutes following medication, if improves, after 30 minutes following medication, they can return home. As a separate line, advise if they fail to improve 30 minutes following medication or, and this would probably be a separate mark and would fall into that grouping category, so I wouldn't be putting both of these, or if they develop stridor at rest, they should immediately attend the emergency department. 2 marks there for that safety net aspect of you're not just saying, here's your tablets, good luck, go out. You really do need to make sure for croup cases, because they crash very, very quickly when they do become sick, that you've got that safety net in place. They know what to do if things don't go according to plan. Now, a bit of kind of more generic upper respiratory tract infection advice here is to encourage, but do not force, small sips of fluids regularly to try and keep up the hydration. These are kids that it's often quite uncomfortable for them to swallow, and so they can dehydrate quite quickly. 3-year-old as well, they don't tend to have as much reserve, and it's a tricky thing because hypertension is a really late sign of decompensation in kids, so you really want to try and make sure you've got a buffer there because it's one of those ones that can be missed. Now, good to specify here, do not force, because if you cause distress to a child with croup, you are going to make their airway compromised and make it more difficult to manage. And so it's more that gentle reminder, have those drink bottles handy, just a clinical tip. And of course, symptom management, commence paracetamol or ibuprofen if Billy has pain / is grizzly. Now, massive overcoding on that response there, so I would put commence paracetamol for Billy if he has pain, or ibuprofen if he is grizzly. You can tie that back and forth as long as you're putting some kind of sensible response in that ballpark there, you're going to get a mark. Now, coming in from the chat here, we've got transfer to ED. And yes, moderate severity croup, I think if this was something that you didn't feel comfortable managing yourself, it's actually not unwarranted, I think, to transfer to ED. And I think you probably would be getting probably 1 mark for that if you did have particular concerns. I think in this case in particular, the thing that they're trying to steer here is this child does have normal vital signs, normal respiratory rate and good oxygen saturations. And so I think it would be, for a consultant level exam, I think what they're trying to tease out here is this something that you think you are able to manage? And I think they're pushing more for that. I'll be honest though, yeah, I think you still would get 1 mark for transfer to ED. Dexamethasone, fantastic, and positional, setting them up. I think that's certainly an important thing to do. Positioning is a really, really key thing for management, probably heading more towards that moderate to severe croup in terms of putting them into a position that they can maintain themselves and trying to touch them as little as possible. So, well done. All right, we do have another question here. Let's get 2 minutes on the clock, and your time starts now. Question 3.3. Billy's parents returned that evening, panicked. Billy is crying, seeming drowsy and pale. They tell you his condition had worsened slowly over the day until he became upset after the TV was turned off. His condition rapidly deteriorated, and in a panic, they drove to your clinic only a minute away. You bring them to the clinic procedure room. What is your initial management actions? Provide 5 management actions. Doses are not required. Alright, time is up, and let's have a look at some answers here. So, in this situation, the patient has obviously progressed through to serious croup, and I anticipate you're probably experiencing some anal flutter. This is one of those times where you call for friends, and my friends in this situation are 000 for an emergency transfer to the emergency department. So I think for 3 marks there, you need to specify that it's 000, it's an emergency transfer, and destination to emergency department. Seems pedantic, I know, but this is one of those things that comes up again and again. 3 marks for those 3 components. Now, in this severe case, we're going straight to our nebulized adrenaline. So you can just use the 1 in 1,000 adrenaline ampules, just cracking open one of the 5 ml ampules straight into there. Now, of course, to get 5 ml of it, you're cracking open 5 ampules. And having gone through this myself, it takes a while, it takes a bit of practice. And you're sitting there trying to draw up all this adrenaline while the kid's sitting there desperately trying to breathe in front of you. You've just got to take a deep breath, step through, and get through. Now, anyone that's tried to give nebulized adrenaline to an unwell child knows it's not a pleasant experience for them, and they will not let you put a mask on them. So sometimes just having the mask nearby so that the nebulized mist is spraying to their face is one way to start getting it in, and as they start to perk up a little bit, you can hopefully get a mask on them then. But it's essentially try and disturb them as little as possible, because with croup, with that upper airway obstruction, really easy for them to again become upset and decompensate. Now, we gave some dexamethasone earlier, but we're going to be giving more dexamethasone. The goalposts have changed here, and we need to up that dose to 0.6 milligram per kilogram, up to 12 milligrams. That can be given orally, as we may have done earlier, or you can give it intramuscular or IV, depending on how quickly, how aggressively you want to manage. Acknowledging as well, though, that those other routes may actually cause more distress than it's worth. Here you definitely get marks for minimising handling to avoid worsening symptoms, given the profound impact that it'll have on trying to aggravate the child, causing worsening symptoms. Of course, keep the children with carers to try and reduce stress, have as many familiar things around them as possible to help calm them down. A calm croup is a croup that lives, and as has already been specified earlier, allow the child to select their position of comfort, however they want to sit. And in a couple of cases, one of the cases at least, the kid just wanted to sit upside down on the bed. Sure, that's fine. That's how he was comfortable, and that's what we let him do. Now, one point that has come up time and time again is for these cases, obtaining intravenous access is actually recommended to be deferred given the distress that it actually places on these children. Of course, if the patient becomes unresponsive, unconscious, those goalposts change, and I think it would definitely be warranted. But while they're in that kind of conscious state, you're really trying to disturb them as little as possible. And so again, I don't think we would get marks in this setting. And to be honest, in this setting, if a child did become unconscious, I'd be very tempted to just pull out intraosseous, given these are kids that are probably quite dehydrated already. And when you're struggling to get access on a child, you can waste a lot of time fluffing about trying to get intravenous access, particularly if it's not a skill that you practice often. I think often much safer, much easier, so much faster. Just pull out an easy IO and put an intraosseous line in. Presuming you have one handy and, of course, are comfortable doing it. If you're not, please do some YouTube videos, do some training. It's a very, very handy skill to have, particularly if you're working in a regional or remote setting. All right, so let's have a look at what our responses are here from the chat. So we've got Ambos 000, fantastic, very well done. Oxygen, this is another one of those things where there's a little bit of ambiguity for this patient here, to be honest. Yeah, I actually would give you marks for oxygen. You know, they're drowsy and pale, they're hypoxic. Whether or not you actually strap a mask on them, or similar to the nebulizer, just have it nearby, getting a bit more kind of passive, increasing their FiO2. Nebulized adrenaline, brilliant. IV line, already spoken about that. I probably wouldn't give you a mark for that one in this setting unless they did become unconscious or further deteriorated. And more dexamethasone, fantastic. Very well done there. From Jenna here, we've got regular monitoring of vital signs. Yeah, not in here, but actually very, very important. I don't know if you get a mark for this question here, for the specific thing here if they've said, what is your initial management actions? Whereas that would probably veer into that territory of ongoing management. Sorry to be pedantic. Call ambulance to organise ED transfer. Excellent. That would get you 2 marks there. I think, I know it's stupid, I know it's pedantic, but specifying urgent gets you the 3rd. Keep Billy calm and quiet with his parents. Fantastic. Really love that. Start oxygen, as I said, yep, I would be giving you marks for that. And give stat dose of prednisolone. Fantastic. Very well done. Excellent. Well done, guys. And I'll finish up this case by saying that croup is one of those things that we do see a lot as GPs. And again, I work in a rural and remote setting where sometimes we are the local ED that they come to. This case here is a case I've actually seen where this happened. The kid did deteriorate and they brought them into us and we had to manage them until the ambulance got there. So the college will likely give cases like this where you're expected to think, you know, well, what kind of things do we have in a GP clinic setting to manage an emergency case? I think more often than not, though, you probably would see them switch the location here to an ED setting, and I think that's where you would probably see more things like intraosseous access or urgent referral to PEDS for consideration ICU, things like that. All right, let's move on then. Well done, guys. Of course, we're going to be keeping up these live streams again. I did say at the start, if you didn't catch it at the start, I'm going to mix it up a little bit. I've had so many requests to do a bit of CCE practice, given the CCE is only a little over a month away. The Zoom link will be in the, or is in the title. No, not the title. The description of this live stream tonight. Oh, that was a brain fart. Description for this live stream tonight. So save that somewhere, put it in your calendar, and I'll be including that link as well on the 3 videos that come out as a result of this, and putting a few posts up just to try and let people know. Of course, if you have people or know people that are studying for the CCE, let them know. I think the more we can get, the merrier. If I can, I even may have a couple of additional faces to act out different patient roles as well. I'd be aiming to get through 3 or 4 different cases on the night. Of course, I would really love it if we could actually get recordings of it as well, so that they can be put up on YouTube as we do for these ones here, to be building up a bank of resources for those that come after. So I think we'll probably leave it there for tonight. We're a little over an hour again. Thank you for joining. I really can't do this, and I wouldn't do any of this if we didn't have people jumping in and making it so worthwhile, giving that feedback. And I hope that the feedback I'm giving as well is making your journey a little bit easier. We'll leave it there for tonight then, if there's nothing else people want to throw into the chat. But I would say you guys are absolutely smashing it, and I don't think you're going to have any troubles on the actual exam day itself. So you're putting in the work, you're putting in the effort, it's paying off. Well done. So leave you guys to it then. I'll see you on next Thursday, logging into Zoom, and hopefully again, as I said, we'll have this put onto YouTube as well for an ongoing resource. Until then, have a great week. See ya.